Hello everyone and welcome to the latest webinar from PDC Mums and Bumps. Today we're talking about pregnancy with gestational diabetes. My name is Caitlin Parker. I'm an accredited practicing dietitian, credentialed diabetes educator, and I am the dietitian as part of our PDC pregnancy clinic. Today we'll be covering a couple of different things. We'll talk about what gestational diabetes is. We'll talk about what to expect through the weeks up to birth and postpartum. We'll talk more about nutrition or diet and exercise management tools. We'll talk about monitoring blood sugar levels and we'll talk about medications. Just a reminder that the information presented in this webinar is general in nature. So every body and every pregnancy is different. Use this as a general guide of what to expect. As with all things related to diabetes and pregnancy, you could be the exception to the norms. So it's important to consult with your healthcare team about your individual circumstances. So starting out, talking about what gestational diabetes is, we use the abbreviation GDM a lot during this presentation, and it stands for gestational diabetes mellitus. GDM is diagnosed when higher than normal blood sugar levels are first detected during pregnancy, and it tends to be essentially temporary. So most women who are diagnosed with gestational diabetes will no longer have diabetes or elevated blood sugar levels once the baby is born. It is a bit of an indicator about how your body reacts when you have increased insulin resistance, though. So women with gestational diabetes are more at risk of developing type 2 diabetes later in life. They've recently done a bit of a revision around the terminology for gestational diabetes. So previously, if high blood sugar levels were detected during pregnancy, everyone was diagnosed with gestational diabetes, and then the diagnosis was revised after the baby was born. Currently, if your higher blood sugar levels are or meet the criteria for a diabetes diagnosis outside of pregnancy, they will now call it overt diabetes in pregnancy. But a lot of the management is still the same, and your healthcare team will kind of look at your situation and make decisions based on what your body and what your blood sugar level is doing. There are certain risk factors for developing gestational diabetes. So the first one is being a family history of type 2 diabetes or a first degree relative, so mother or sister who has had gestational diabetes. Having had gestational diabetes in a previous pregnancy, having had previously elevated blood glucose levels. People from different backgrounds are more at risk. So people from an African, Melanesian, Polynesian, South Asian, Chinese, Southeast Asian, Middle Eastern, Hispanic, or South American background, as well as being a First Nations woman. Having polycystic ovarian syndrome, which has now been reclassified as PMOS. Having previously given birth to a large baby weighing more than 4.5 kilos, currently taking some types of antipsychotic or steroid medications, and being above the healthy weight range. In terms of what actually causes gestational diabetes, so the placenta, which produces a hormone or hormones, which help our baby grow and develop, those hormones also increase our insulin resistance. So if we think of our body like a system or like keys and locks. So when our blood glucose level becomes higher, our body releases insulin, which is a hormone that functions like a key. The insulin will open the door to your cell or unlock the cell so that the sugar can go into your cell and we can make energy. When we have insulin resistance, which is what is caused by these hormones, Um, if you think of it as the lock becoming rusty or the key not really working anymore. So the body has a lot more trouble unlocking the cells so that the sugar can go into the cells and be used. During gestational diabetes, we have insulin resistance, and because of that, we don't have enough insulin that works effectively to let enough of the sugar into the cells. Because the sugar can't go into the cell, it stays in the blood. So that's what causes that increase in blood sugar levels. Our insulin resistance tends to progress as the pregnancy progresses. So if this is our normal insulin requirements, or if you think of them as your um, like steady state prior to pregnancy in terms of insulin resistance, generally we need less insulin during the first trimester. And then as that placenta becomes more established and releases more of those hormones, our insulin resistance increases up to around 34 to 36 weeks where it plateaus out. And then as soon as the placenta is delivered, the insulin requirements drop dramatically, or your insulin resistance drops dramatically. It's really important to test for gestational diabetes, and it's important to monitor our blood sugar levels for a number of different reasons. So the first one is that once you're diagnosed with gestational diabetes, you get access to the NDSS, or the National Diabetes Service Scheme, and this gives you subsidized blood glucose testing. So you get the blood glucose test strips for cheaper. It also means that you get the appropriate care and monitoring for both you and your baby. So with elevated blood sugar levels, they tend to look more at the baby's growth and development. We want to monitor our blood sugar levels during pregnancy because we want to make sure that they are kept in target as much as possible. And that is because we want to reduce risks. So for the mum, we're looking at reducing risks of cesarean delivery required, preterm delivery, and preeclampsia. And for our babies, we're trying to minimize the risk of large birth weights, breathing difficulties after delivery, and low blood sugars after delivery. Most of the time, gestational diabetes tests, or the oral glucose tolerance tests, are done at around about 24 to 28 weeks. Some women may be recommended to test for gestational diabetes earlier. So if you've had some of those risk factors that we talked about in the previous slides, they may recommend that you test earlier. They could do this by doing an HbA1c, or monthly average glucose, in your first lot of antenatal bloods, or an early oral glucose tolerance test, ideally between weeks 10 to 14, but this can still be done up to 20 weeks. If you're diagnosed with gestational diabetes with the glucose tolerance at 24 to 28 weeks, typically your pregnancy is no different from a standard pregnancy care up until that point that you're diagnosed with gestational diabetes. If you're diagnosed with gestational diabetes earlier in your pregnancy, your monitoring may be slightly different in terms of them having a little bit more of a look at obviously blood glucose levels, but also how your baby is growing and developing. So we've talked about generally the first trimester being standard care. Moving on to the second trimester, which is weeks 13 to 27, sometimes the monitoring may be a little bit different if you've been diagnosed with gestational diabetes. So as we can see, our insulin resistance, or our insulin requirements, are increasing over this second trimester. And as we said before, it's because of the hormones that are made by the placenta. If you're taking the glucose tolerance test at the usual time, it's done here. So the insulin requirements are above what they would have been prior to pregnancy. You'll have the 20-week anatomy scan. And this is where you can find out the gender if you didn't find it out earlier in your pregnancy. And they may recommend other blood tests based on your risk factors and what your healthcare team recommends. So this may be the point that you were diagnosed with gestational diabetes. And generally, the first line treatment is diet and exercise. And so we'll talk about this in a bit more detail. Your doctor will likely refer you to a diabetes educator with experience in pregnancy and a dietitian. And ideally, we want these visits within about a week of your diagnosis. Moving on to the third trimester. So as we can see, insulin requirements continue to increase and they start to plateau from about 34 weeks onwards. You have a continuation of the routine tests at each of your antenatal appointments, including urine tests, blood pressure, and weight, and they may recommend an additional growth scan at around 28 to 30 weeks. So talking a little bit more about those treatments, so our diet, exercise, and monitoring. So as we said, the first steps are usually diet and exercise or diet and physical activity. We want to start monitoring our blood glucose levels. And then if it's required, medication may be recommended. And this is typically metformin or insulin in pregnancy. Our blood glucose monitoring is typically done using a glucometer. So this is an example of what one might look like. This is typically provided during one of your diabetes education appointments, or they can also be purchased from the chemist. The diabetes educator will also register you with the NDSS, and they will give you a card, and then you can either use that card or your Medicare card to access the subsidy for the blood glucose test strips. Usually, women are recommended to test their blood glucose levels 4 times per day. So before breakfast, 2 hours after breakfast, 2 hours after lunch, and 2 hours after dinner. But this might be adjusted based on your individual requirements. So you might start off with testing 4 times a day, and then they may scale it back as the pregnancy progresses. Our target blood sugars. So before breakfast, we want our blood sugar level to be 5.0 or less. 1 hour after the start of the meal, it can be up to 7.4. And then 2 hours after the start of the meal, we want it to be 6.7 or less. It's quite normal for blood sugar levels to increase after you eat food containing carbohydrate, which is why that 1 hour reading is higher than the 2 hour one. The 1 hour one is in there uh, because depending on how you're feeling and how hungry you are, sometimes it may be better to test 1 hour after a meal instead of two, but generally it's recommended to test 2 hours after the start of the meal. With the testing 2 hours after, so generally you want to have no food in that 2 hour window because otherwise the blood glucose levels will likely be higher. So if you're having a snack, say after lunch, make sure you have your lunch, wait 2 hours, do your blood glucose test, and then you're free to have your snack. With our diet, the aims are to achieve our target blood sugar levels, but also to make sure that there are enough nutrients for both you and the baby during pregnancy and beyond. And we also want to try and start some healthy habits so that we can reduce the risk of developing type 2 diabetes later in life. Almost everything in terms of diet and blood glucose management is to do with carbohydrate. So this is the main nutrient that we focus on to help manage blood sugar levels. When we say carbohydrate, we mean both starchy foods, so things like rice, pasta, noodles, bread, crackers, anything with flour in it, as well as sugary foods. So these could be foods with natural sugars like fruit or milk, but also added sugars, so things like cakes, biscuits, lollies, chocolate. So both sugary foods and starchy foods are carbohydrate foods. We don't need to cut these foods out. So our baby needs carbohydrate for normal growth and development. And it's a general consensus that it's recommended to consume 175 grams of carbohydrate each day. They arrived at this number because it's enough for the fetal brain development and it also prevents ketosis in the mum. Quality is important, so we're looking for slow release, nutrient dense carbohydrates. So, including foods with plenty of fiber, vitamins, minerals, so lots of good stuff in those foods. We've got this target of 175 grams of carbohydrate per day, but we want to spread that carbohydrate out so we're not having too much carbohydrate in one sitting. That's going to help us to manage our blood or control our blood glucose levels throughout the day. So the suggested split is 30 to 45 grams of carbohydrate for the 3 meals, so breakfast, lunch, and dinner, and then 15 to 25 grams of carbohydrate for 2 or 3 snacks per day. These targets, so 30 to 45 grams of carbohydrate for our meals, we can create these amounts using carbohydrate portions or carbohydrate exchanges. And these are like building blocks that we can use to build the carbohydrate in our meals. Or we can use apps to help us carb count the amount of carbohydrate in our meals. So carbohydrate portions or exchanges are amounts of foods that equal 15 grams of the macronutrient carbohydrate. So a lot of the time they'll talk about it in terms of 2 to 3 portions of carbohydrate at our meals, which is 30 to 45 grams, and 1 or 2 portions of carbohydrate at our snacks. So it's around 15 to 30 grams. We can top up our meals and snacks with low or no carbohydrate foods to help fill us up and provide us with extra nutrients. So these would be things like meat, egg, tofu, cheese, and low carb veggies. These are some examples of what those 15 grams portions would look like. So it could be something like a cup of milk, half a cup of flavored milk, half a tub of higher sugar yogurt, so about 100 grams, or 200 grams of natural or diet yogurt, a large scoop of ice cream, a medium piece of fruit like an apple, orange, or pear, 2 or 3 small pieces of fruit. So the example there is apricots, but it could be things like plums and kiwi fruits, a small banana, 20 grapes or cherries, 3/4 of a cup of fruit salad, 150 mils of 100% fruit juice, half a cup of mashed potato, 1 medium raw potato, things like half a cup of corn or a medium corn cob. It could be things like 4 Vita-Wheat biscuits, a slice of bread, 1/3 to half a cup of cereal or 1.5 Wheat Bix, 1/4 to 1/3 of a cup of cooked rice, which is as the rice cooks, it gets bigger. So the volume is measured when it's cooked, or 1/3 to half of a cup cooked pasta. Again, the pasta is bigger as it's cooked. So the portion that has the 15 grams of carbohydrate is measured cooked. If we talk about that 30 to 45 grams of carbohydrate at our meals and then 15 to 25 grams of carbohydrate at our snacks, this is what it could look like. So for breakfast, we could have something like porridge made with milk topped with fruit like berries. We could have a milky coffee, so like a flat white with a handful of nuts. We could do a sandwich with a protein filling and vegetables for lunch with a piece of fruit like an apple. We could do 3 or 4 Vita wheat crackers with cheese and then a low sugar yogurt like this YoPro one shown here. A lot of the time with our dinners, we don't necessarily need different food or special food. It's often just the proportions of the meal that are changed. So here we've got us something like spaghetti bolognese with perhaps a smaller serve of the pasta. The protein comes from that mince-based sauce, and then we're filling out the rest of our plate with low carbohydrate vegetables like salad. And then before bed, you might have something like a piece of fruit toast with peanut butter. Here's some more examples of um, how these different meals can look like. So the examples for breakfast would be something like a Lebanese flatbread, which is containing majority of your carbohydrate. And then we've got free foods like eggs, cheese, tomato, onion. Or it could be 2 slices of bread or toast with avocado and a small milky coffee. It could be 3 Weet-Bix with milk or 2 Weet-Bix with milk and a piece of fruit. Our snack could be something like a medium piece of fruit and a cup of tea or coffee with a low amount of milk in it, lower amount. We've got something like lunch could be rice with veggies and a protein, or a variation of a noodle soup with meat and veggies, or it could be something like 2 chapatis with dal or curry and then some veggies on the side. Snacks can be things like crackers and cheese with some fruit, or some dried fruit and nuts and a cup of tea, or yogurt and a banana. And then we've got dinner. So it could be things like pasta or noodles with a protein and some veggies, or it could be semolina with some lentils and meat, or it could be flatbread with yogurt and chickpeas and a salad. And then our snack before bed could be something like a cup of milk and a piece of fruit. There's lots of helpful handouts with extra information about all sorts of things to do with food. And I've got the links to these ones on the last slide. NDSS has a lot of information about carbohydrate counting, and they talk about it in terms of grams of carbohydrate. And then this gestational diabetes handout has all sorts of information about types of foods, carbohydrates, and examples of meals. So that was all about counting carbohydrates in terms of carbohydrate portions. We can also just look up the amount of carbohydrate in food. So an example of that is the Calorie King website. So it can either be a website or an app, and you can basically search for different foods and it will tell you the carbohydrate content of those foods in the specified serve sizes. When you go to this website, just make sure it's on Australian food. So if you can see the Australian flag down here, it means you're probably in a different country. So just click the Australian one and it will give you the correct types of foods. Easy Diet Diary is a great app. So it's a free one and it's basically just a food diary app. If you scroll along this top ribbon here, you can select carbohydrate and it will put a carbohydrate column in your food diary and it will total the carbohydrate of your meals. The only thing to be aware of with this one is that it will likely calculate you a calorie or energy target, and just ignore it because it's not accurate for pregnancy, or it's not what we're looking for in this situation. We're focusing more on the carbohydrate. So we've talked about amount of carbohydrate. Now we'll talk about type of carbohydrate. So we want good quality carbohydrates with lots of nutrients in them. And we also ideally want them to be slow release. When we talk about slow release in terms of carbohydrate, we're talking about it in terms of low GI. So GI is a number that's given to a food based on how quickly the food is broken down and released into your blood. A high GI carbohydrate will cause a spike in your blood sugar level and then a drop, whereas a low GI carbohydrate is broken down much slower, so helps to keep our blood sugar level steady. If we're having high GI carbs and we're testing our blood sugar levels, it may be that you're more likely to find a blood sugar level that's higher. as opposed to a lower GI um, level, which is a lower GI carbohydrate, which keeps our blood sugar levels steadier and lower. Low GI carbohydrates are things like our lentils and legumes. It can be things like orange flesh sweet potato. Most of our white potatoes are high GI, except for some specific types like charisma. Corn is a great example of a low GI carbohydrate. Rolled oats as opposed to instant oats. Grainy bread as opposed to white bread. Most of our fruit is low GI, apart from rock melon, watermelon, and fruits that are canned in syrup. And then our milk and yogurt is low GI. There are some foods that you may not be able to find a GI value for, so something like cheese, and it's because they're so low carbohydrate that the glycemic index isn't really relevant. We can also lower the GI of our meal with different strategies. So adding fiber to our meal can help to lower the GI. So whether that's a fiber supplement like psyllium or whether it's including vegetables, adding a protein food to our meal will lower the GI of that meal. Adding a fat, ideally an unsaturated fat, so something like avocados, olive oil, or nuts, and adding acidity to our meal. So whether that's a vinegar-based salad dressing, um, or a more acidic fruit, for example, so something like oranges maybe. The other part of our management strategy is exercise. So if you think about exercise as your medicine, it can help reduce our blood glucose levels independent of insulin. So the rules of insulin resistance don't really apply to exercise. Both our aerobic exercise, so things like walking, cycling, swimming, and resistance training, so things like weightlifting, are beneficial to blood glucose levels. And if we can improve our blood sugar levels, it can reduce our risk of having a larger baby and needing medication. If you're having problems with your blood glucose level 2 hours after your meal, so that 2 hour test, having a 10-minute walk after the meal can help reduce that number. With our exercise targets, what we're looking to do is include some activity every day. We're aiming for at least 30 minutes of moderate intensity physical activity most days and some kind of muscle strengthening activity twice per week. If we're having trouble with moving a lot or standing for a longer time, we can break this exercise up into 10-minute blocks. It's important to remember to build up slowly. So now is not the time to start something new. If you're already active, um, maintaining your level of activity and then lowering the intensity or modifying the exercise as it's required during pregnancy. Um, Starting small and building up is a great strategy. Sometimes to manage gestational diabetes, some women may need medication alongside this healthy eating and physical activity. It's really common for women to worry about this. And it's important to remember that needing medication doesn't mean you have failed or done something wrong. Sometimes your body just needs a little bit more help to overcome the insulin resistance that's caused by the placenta. Insulin is often recommended for managing blood sugar levels in pregnancy because it's shown to not cross the placenta. And the impact of metformin, which is often the other option, has been well researched. So metformin is a tablet and it works to reduce blood sugar levels in a number of different ways. So it tells the liver to stop releasing so much stored sugar, and it also reduces that insulin resistance, so helps your body to use more of the glucose. It's usually recommended for mildly elevated fasting or mildly elevated overall blood glucose levels. And this reduces the risk of low blood sugar levels in the baby after it's born. If insulin is recommended instead, this is an injection. and it physically replaces the insulin, or I suppose adds to the insulin that your body would normally make. Um, Sometimes the injection is once a day or twice a day, or sometimes it's more often, depending on how much extra help your body needs. A diabetes educator can teach you how to give the insulin injection, and typically it's quite a small needle in comparison to something like a vaccination. We can get intermediate acting insulin, which is kind of like covering the background insulin requirements across the day and across the night. And we can also get rapid acting insulin, which helps to cover the carbohydrate at our meals if it's needed and can bring down high blood sugar levels. The doses will likely be adjusted as the pregnancy progresses. If you remember that insulin resistance continues to climb until about 34 to 36 weeks. So it's likely if you need insulin, you may need more insulin as the pregnancy progresses. Typically, your healthcare team consists of a number of people additional to what a standard pregnancy healthcare team would. So we've got the diabetes educator. Their main job is to start you off with monitoring blood sugar levels. They can help with reviewing blood sugar levels, and they can make treatment recommendations. The dietitian, so they are looking at giving you information to help you manage your blood sugar levels with diet, but they will also make recommendations about your total nutrient intake and kind of like recommend foods in general. They'll also help you to work within the pregnancy or gestational diabetes guidelines so that you can still eat the foods that you actually like eating and adjust them based on the preferences of both you and your family. In terms of exercise, there may be a couple of people that help you here. So a physiotherapist is a good one if you've got any musculoskeletal conditions or pain. And an exercise physiologist is someone who essentially prescribes exercise to help you manage health conditions. So they may prescribe you some exercise to help manage your blood sugar levels. Moving on to talking about birth and what to expect. So most women with gestational diabetes will be able to deliver close to their due date, but induction might be recommended if macrosomia or a large baby is suspected. So if the baby is growing too much or too big, your healthcare team might suggest inducing your birth 1 to 2 weeks earlier. And this is to reduce risks of any complications. With your medication, so usually metformin is stopped just before labor or the C-section, so either the day before or a few hours before. Insulin is titrated during labor, so the doses are changed based on what your blood glucose levels are doing. Your blood sugars will continue to be monitored during birth, and then they will suggest treatments accordingly. The target blood sugar for birth is between 4 and 7, so quite similar to what the day-to-day monitoring numbers are. If your diabetes or gestational diabetes was treated with diet and exercise, blood glucose monitoring generally stops after birth. If you were treating it with diet and exercise and medication, the medication usually stops after birth, but the blood sugar monitoring will continue for 24 hours after birth, and then it will stop if the blood sugar levels are in target. With your baby, so after birth, your baby will be checked by a pediatrician, an obstetrician, or a midwife, and they will be carefully monitored for the first 24 to 48 hours. One of the things that they're looking at is the blood glucose level of the baby. So when the baby is in your tummy, its pancreas is working fine, so it's making insulin, and it has access to sometimes a higher amount of glucose than what a mother without diabetes would give to their baby. Because of that, your baby is used to making more insulin than it would if the blood sugar levels weren't higher. So when the baby is born and it then relies on its own blood glucose levels, sometimes it makes a little bit too much insulin for that first 24 to 48 hours. So the midwives are keeping an eye on what the blood sugar levels of the baby are doing, making sure that they don't go too low. At 6 to 12 weeks after birth, Most women who were diagnosed with gestational diabetes in pregnancy will no longer have diabetes, but they recommend doing a repeat oral glucose tolerance test at 6 to 12 weeks. And the main reason for this is to make sure that the blood sugar levels have gone back to normal. Being diagnosed with gestational diabetes means you're at higher risk of developing type 2 diabetes in the next 10 or 20 years. So although you don't have to be as strict as you likely were during pregnancy, making healthy food choices, being physically active every day can reduce the risk of developing type 2 diabetes for both you and your family. Here are the links to those fact sheets that I mentioned before. So the one that's about general guidelines for gestational diabetes is this one, and then these are those two or three carbohydrate counting ones. And then we've got a couple of extra resources there too. Please let us know if you have any questions. We're happy to talk more about gestational diabetes or answer any questions as they come up. Thank you all for listening.